Welcome to this webinar about reaching zero-dose children and the importance of human resources for reaching missed communities. This is the third webinar in a series of 4 that the Zero-Dose Community of Practice is doing together with TechNet 21. And we are going to have 3 very exciting presentations today. Before I hand over to Alyssa Sharkey, who is going to lead the webinar, I just would like to remind the participants about two things. If you would like to chat among yourself and introduce yourself, please use the chat function, the one at the bottom where it now says the red 2. But if you want to ask questions during the webinar to the panelists, please use the Q&A function, which is just to the left of the chat, and type your question there, and we will pick them up. We will answer those that we can answer in writing during the presentations and during the discussion, and some of the questions will be answered live. Those are the only 2 rules. So please engage from the start, and we hope to have a very exciting webinar here. With those few words, I'm handing over to Alyssa.
Thank you so much, Nicholas, and it's such a pleasure to be with all of you today. Thank you, everyone, for joining. We're so excited that we have several really exciting presenters for today, and so we hope to go through those 3 presentations, and then we will allow some time for good discussion with all of you, because I'm sure many of you have really interesting experiences to share with us. So I just first want to introduce, I'll quickly just tell you who our panelists are today, and then we will go right to the presentations. So our first speaker today is Rie Takasue, and she's a health specialist at the Primary Healthcare Health System Strengthening Unit at UNICEF's headquarters in New York City. Thank you so much, Rie, for joining us. After Rie, we will have Dr. Abdul Jabbar, who is an additional director for the EPI Punjab program in Pakistan. We're very grateful for your participation, Dr. Jabbar, particularly given the current emergency situation in Pakistan. So very much appreciate your time with us. And then our third speaker today is Mr. George Mwinya. And George was a frontline health worker in Ghana for quite a while. He's now working on his PhD at Johns Hopkins Bloomberg School of Public Health. So it'll be really interesting to hear George's perspectives on being a frontline worker and what might be needed to improve the situation. So very excited about these. I think I'll just turn over now without any delay to Rie. Rie, please go ahead with your presentation. You have 10 minutes. Thank you.
Thanks, Alyssa. Good morning, good afternoon, and good evening to everyone. My name is Rie Takasue from UNICEF headquarters. So today I have a pleasure to talk about the challenges in reaching those communities with the perspective of human resource for health. So by 2030, we estimate that we have a shortfall of 18 million health workforce around the world. And this problem will be more bigger in low and middle income countries. So as you remember, in 2018, countries have committed to strengthen primary health care for achieving the universal health coverage in Astana. So now we have the ongoing COVID pandemics have gave us 2 important lessons. The first, we observed that health system in most countries are weak. So we need to make substantial effort and investment for rebuilding resilient health systems for preparing ourselves for the future health emergencies. And we have also observed inequity in accessing essential health services. And unfortunately, the many gains that we had pre-COVID has been reverted. So we need to reinvest on human resources, particularly for PHC. So those communities do exist in two aspects. One, the health services do not manage to reach to the community. And the other side is that the population, the people, are not accessing or do not come or do not manage to come to access the health services. Next, please. So today I'd like to start with 3 challenges. The first is availability of health resources. So in those communities, in remote areas, even the health workers, skilled health workers might not find comfortable working environment as well as living conditions, not only for their medical services, but maybe not for the education of their children. So many people prefer to stay in big cities or big towns. So that causes maldistribution of the human resource. And another side is the capacity. So we know in some countries we have some issues of the quality of basic medical education. But at the same time, it is important to have the regular trainings for the continuous education. Next, please. So the second point is the acceptability. So those human resources, the gap, build the bridge between the health facility and the community. So we need somebody who understands the local context. So it sometimes helps to have somebody from their community, from the same ethnic background, caste, understand the language, understand the religion, and also the gender helps. So the other point is adjusting the health services with time and location. For example, when during the harvest season, if you only provide the immunization service early in the morning, people are not there. So it'd be helpful to be flexible with the service delivery as well. Next, please. And the third point is the motivation. So let's imagine that you're a health worker in those communities. It's often remote, and you might not have the, you might often have the stock out of medicines, and you might not have a doctor who is supposed to be in the post. And there's no opportunity for promotion, career development, and the road coming to the village is often closed, sometimes because of the rain, snow, or other issues. Or you might not have a means of transportation, or you might be there for a long time without knowing when you would be moving next. So in this situation, so this is the typical situation of those communities. So if it was you, what do you think would be the effective approach to keep your motivation and that leads to the retention? Is it better salary or a regular supportive supervision, or having a doctor maybe once or twice a week from another health neighboring facility, or having a medicine in stock all the time, or you have a promotion, a better career development, or maybe having a local government maintaining the road to have access, or you might be it might be helpful to have, let's say, motorcycle or any other means, or maybe the rotation policy to have the limited duration, and maybe you will have a better condition in the next 10 years. Or could it be scholarship for your children, for example? So some of these ideas, you might have it in your policy. Or if it does exist, is it budgeted? Or is it really implemented? Or it might happen to some people, limited privileged people, but not to everyone. So we need to have this kind of we need to have the policy implemented to ensure these overcome these three challenges. So today, after my presentation, we'll be listening to a more concrete example that gave the change in the society. So I'm very much looking forward to learn from our colleagues, and we are also looking forward to receive many questions, critiques, and exchanging ideas in this interactive webinar. Thank you very much.
Thank you so much, Rie, for that really comprehensive and good overview of some of the big challenges that we have with respect to human resources for health. And thanks for highlighting, I think for zero-dose communities, obviously, these challenges are quite prevalent and important. Next, we'd like to turn to Dr. Jabbar, who's going to speak to us about some of the work that they've done in Punjab, in Pakistan, to innovative ways to improve the situation for human resources for health there. So Dr. Jabbar, over to you.
Thank you, Lisa. Thank you very much. Good afternoon to everybody. While considering the reaching every child, we have multi-pronged strategies. First, I would like to share what we take the definition of zero-dose children. Generally, we take the definition of zero-dose children are those who have not received any of the routine vaccine. For operational purposes, all those children who are missing the first dose of DPT containing vaccine, Penta 1, which is being used in EPA Pakistan in our schedule, in our national schedule. If the child missed that dose, we label it as zero-dose child. The latest TPVAC surveys conducted by Aga Khan University, Karachi, declared that we are having only 0.9% of the total eligible children as zero dose. This is the success story of Punjab. The second terminology I would like to share with you is under-immunized or incomplete immunized children. All those children who have received a full course of routine immunization, say for example, a child has received one dose of Penta 1 and Penta 2, and he dropped the third dose of Penta 3, we label that child as under-immunized child. The TPVAC's latest survey done in Punjab, we have the lowest percentage of partially immunized children in whole Pakistan. That is 10.7% of the total children. Next, please. What the strategies we adopted to cover these zero-dose children in Punjab? First, we have requested our government to increase the number of HR, human resource, especially the skilled vaccinators. We have recruited 2,000 new vaccinators in Punjab, especially as our colleague already said, that we have also, not only we have increased the number of vaccinators, we have also given the proportionate, the areas which are weak, the vaccinators were deployed over there. Moreover, their capacity was built at different levels. The second strategy was establishing new EPI centers. The public sector hospitals, they were encouraged to come with us and to improve our coverage services, EPI coverage services especially. We have established 260 new EPI centers in Punjab. The mechanism is they come with us and sign an MOU. They give us the data and we give them logistics support. The HR support is from the private sector. We train them, built up their capacity, and then deploy them in their private hospitals. The third strategy was the enhancing outreach activities, especially this is from WHO support, especially during pandemic, COVID pandemic. Most of the provinces of Pakistan, they have halted their EPI services, but Punjab has a different story. Through enhanced outreach activities, we have, in spite of the COVID pandemic, we sustained our services during that crisis situation. The next strategy was the initiation of birth doses at birth rooms. The Department of Health have a notification to improve immunization services in public sector hospitals. All the hospitals, teaching hospitals, RSCs, DHQs and THQs, they were requested to expand the network of the birth doses of OPV and hepatitis B birth dose and BCG were given in labor room. The labor room staff nurse were trained, their capacity was built, and they were requested through their administration for the initiation of birth dose at labor rooms. Next, please. This is a marvelous initiative. The evening shift of routine vaccination in public sector hospitals was introduced. The administration was requested to prevail their services, health delivery services in the evening hours, especially the labor class, those husband and wife, if they are working class, they can't spare time for their children for API services. They were giving leverage and relaxation of time. They are supposed to come in the evening hours to get their eligible children vaccinated. This EMR application for real-time child level data is a marvelous success story of this Punjab province. Say, for example, I am a vaccinator. I go for outreach services. I vaccinate the eligible children, and then and there I upload the real-time data on electronic medical registry application. This application is run by HISDU, Health Information and Service Delivery Unit of the department, and the real-time data can be shown then and there. The next strategy Punjab adopted was the strengthening of supervision and accountability. All EPI indicators, especially zero-dose children, FIC, and others. They were included in CO deck in the monthly meeting of Secretary and Minister. They themselves attend those monthly meetings, and track and assess the performance of the district health authorities. This accountability mechanism, they are answerable to the health secretary as well as Minister for Health. So they are already vigilant for their EPI services. Next, please. PE-EPI synergy has helped in improving identification of the children, their coverage, tracking of zero-dose children, and their validation later on. Punjab took key initiative for zero-dose children. There were three major strategies for the coverage of zero-dose children. One was SES application dashboard. All the zero-dose children are being recorded during SIAs. The list of these zero-dose children is shared with the relevant stakeholders. Due and defaulter children are segregated age-wise, and high-risk mobile population, HRMP population, is put on the table in front of the health managers. Then they share this data with the vaccinator of the Union Council so that he can cover those children which have been missed one way or the other. The second component of this strategy was HR and MP, high risk and migratory population registration. Whenever there is the migration of population and the eligible children have not been vaccinated, they are labeled as zero dose, identified prior to SIA. This is the preparation of SIA. They are vaccinated then and there. Not only polio drops are given to them, but routine vaccinations are also administered by EPI technicians. The third strategy for zero dose coverage and validation was that data validation especially. Say, for example, I am a health manager. My team says that I have covered all the zero dose children. They don't believe in me. They themselves validate 10% of the total selected covered zero dose children. And then they are happy with that. Okay, your data is okay, your data is valid. Next, please. This is the profile of Punjab. We have got 36 districts, 153 tehsils, 3,527 UCs, DHQs, BHU, and 24/7 BHU. 24/7 BHU contribute a lot. Say, for example, routine BHUs, they are giving services, including EPI services, only in the morning time. 24/7 BHUs, the staff and LHV, they give labor room services round the clock, along with EPI service delivery. So these BHUs, 24/7 BHUs, they contributed a lot for EPI coverage. Next, please. Zero dose recording and coverage through PEI EPI synergy team operating through EOC. Priority UCs, weak UCs from the last SIAs and from the last years, they were selected. EPI and PEI partner staff, they identify the unvaccinated and defaulter children during priority UC support cluster. All the recorded children who were found unvaccinated are defaulters. The data of those children are being shared through dashboard to the districts. Then the district managers are supposed to share that data with the relevant vaccinator of the UC to cover those children. AFP zero dose children, a list of all zero dose AFP children ranging from 0 to 59 months of age, that is shared with the concerned UC for vaccination after stool sample collection. This is the baby of AFP surveillance of polio. Based on all zero-dose AFP children, a 30 household cluster being taken from the area to assess EPI status of the other children, whether they have been vaccinated or not. The list of all these children which were eligible for vaccination, but they were not vaccinated, due to one reason or the other, that data is being shared with the district managers to the vaccinator to cover them. All the recorded children are shifted on SES application, that is Synergy Evaluation System application, for timely sharing and feedback till UC level. Say, for example, during my visit of polio campaign, if I found any unvaccinated or zero-dose child, I upload the detail of that child on SES system. Automatically, the system picks up the data of that child to the relevant UC of the vaccinator to cover later on. Next, please. EPI SIAs like TCV campaign, MR campaign, and fragmented IPV campaign, all these social mobilizers are trained to record all zero-dose children followed by vaccination. This is another mechanism of finding those children which were neglected by our vaccinators. Through EOC support, health camps has been conducted in many weak areas of Punjab. Our workers, they have the referral slips. They visit the house and record the zero-dose children and defaulter children for EPI, along with the other camp activities. Minor ailments are being dealt then and there. The referral slips during polio SIA and EOA, they were compiled. The relevant data is shared to the vaccinators through health managers to cover those children. Next, please. This is the zero-dose coverage through Synergy team. See the data against the year. 21, 90, 95%. The activity is listed, children are recorded and then covered, and the percentage. You can see the gradual increase in the coverage data. Say, for example, 361 children were total. 30 household cluster AFP clusters were conducted since launch of SES system from May 2021. 246 children were identified as defaulter and covered for essential immunization services. About 1,400 children were identified as defaulter for IPV. If I know which these are the children to be covered, I can easily cover them through my system. Next, please. This is the data of 2020. Recording of due children, recording of defaulter children, when they are covered, this is the percentage gradually. How the system pick up the recorded children, whether they are due, their vaccination dose was due, or they were defaulter children, or they age appropriate vaccination is not being done. Then when they are covered through this system, this is a snapshot of SES system. Next, please.
Dr. Jabbar, thank you so much.
Thank you very much.
Yeah, Dr. Jabbar, thank you so much. So it's such an amazing, innovative program. You've done things to improve demand and also to support the health workers in Punjab. And I can already see that your presentation has generated many questions. So we will come back to you. It's very exciting. And even some of your colleagues, I think, are online as well. So thank you so much. This is very exciting.
You are welcome. You can ask any question.
Okay. So Thank you so much. So first, let's just switch to George Mwenya, who is going to talk about his experiences as a frontline health worker. So George, we'd like to have you give your presentation first, and then we will start to go through the many questions that are coming in. Thank you so much.
Thank you.
Thank you, Alyssa. And thanks, everyone. So just to give a little context about where I started from, and it is based on this background that I'll be sharing with you my presentation to follow. I started out as a community health volunteer between high school and after high school. Did that for a couple of years, and then after that, I was privileged to attain additional training as a community health worker, which involved a 2-year training, after which you get a certificate in community health, and then you can become a community health officer. So this program operated under the Ghana CHIPS program, which is the flagship primary healthcare program in Ghana. And then from there, to cut things short, I'm currently a student at Johns Hopkins Bloomberg School of Public Health, and contributing to some of the global discourse on immunization, mixed communities, and zero dose. Next, please. So just some things I would like us to keep in mind as we go through the next slides. The first thing is that we need to recognize that in some instances, community health workers will be the only medium through which we will be able to reach mixed communities or zero dose children. Then the second thing is to recognize that logistics and well-paid salary or allowance for community health workers is absolutely necessary, but it is usually not sufficient to reach mixed communities or zero dose children. And the last point to highlight before I proceed to the substance of my presentation is that when we talk of zero dose communities, it comes in different shapes and forms. And in my experience, sometimes the thinking is that zero dose is a community of grouped houses that are close together in the middle of a jungle, and that the problem is how to reach there. But once you get there, the houses are together, everybody is there, you immunize them, and we eliminate mixed communities. That is not necessarily the case. And then in the next slides, I'm going to present some evidence and some of my first-hand experiences providing services in what I define as how to reach communities or mixed communities. Next, please. So just a small recap. Among other things, community health workers in Ghana, we organize child welfare clinics where we weigh children and provide immunization in regular settings. Next, please. In addition to organizing child welfare clinics, we also conduct what we call home visits, where we actually visit people in their own homes to provide various services, including immunization, educating mothers on exclusive breastfeeding, teaching new mothers on positioning, and other things. Next, please. So here is the fun part of the job, something that most of us may be familiar with. There are a couple things I would like to point out here to keep in mind. So like we said, I mean, clearly, as you can see, here we have the vaccines, we have the vaccine carriers with ice chests, you have the motorbikes, you have fuel, we have allowance. But still, that is not all, that is not enough to reach zero dose communities. At the end of the day, you need a dedicated individual, a community health worker who have the desire, passion, and will to be able to make that trek to finally reach that household or to reach that zero dose. In the middle of this, there are things that usually will be more challenging than the physical challenges you are seeing here. And I will be touching on that. Next slide. So think of it. The first component is a community health worker is assigned to a place which involves this physical work to get to the destination. You get there, and personally, I have been through this, where you arrive at a place and it is not a community in the sense of how we always will think of community. You get there and there's one household here. You meet one child who may be 0 dose, and then you provide them with the antigens. Then after that, sometimes you have to walk 20 to 30 minutes to get to the next household. And sometimes you get to the house and the family are not around. Fortunately, in this setting, sometimes they are at the farm, but usually the farm is not very far from the house. So you follow up with additional walking. And there are places with your car and motorbikes. There are instances where you have to pack all that and pick up your load, your vaccine carrier and recording sheets, and just walk, physical walking, sometimes 40 minutes to an hour walk to arrive at one house and to provide this. The challenges you get in this is the target setting, because more often supervisors have a target. They tell you in this place you're supposed to immunize 50 children. Sometimes you will go and the whole day with your best effort, you are able to reach maybe 10 or 20. That means you are not meeting target. As a community health worker, that brings a lot of risks. One, you are likely to be considered as someone who did not work. Two, you may get a reduced allowance because you didn't reach your target. Three, you are less likely to be called for future programs because the assumption is that, oh, that guy is lazy, he doesn't work. And this usually will put a community health worker in a tight corner, especially in this environment where it's extremely difficult to come by jobs. And so the target setting and planning of programs is extremely important to always try to include community health workers. Next, please. In addition to that, you also need dedicated supervisors who will not only just come to ask and collect numbers, but at least supervisors who will appropriately respect and recognize community health workers. Supervisors who will be willing to listen and to be understanding. And that can go a very long way. Something that in many instances, it doesn't happen. As far as you are not meeting the numbers game, like you don't have much respect and you run several rates for future programs. And also, this is a village in Western region Ghana, it's called Eduswazo, where a trip that could have taken like 6 to 7 hours can take supervisors 2 or 3 days to get there due to road conditions. And sometimes these supervisors is not just for supervision, they are also bringing additional logistics. And then this can sometimes really demoralize a community health worker to deliver. Next, please. Again, additionally, showing you conditions that it takes to get to some of the places we serve. Next, please. So here are my key things I would like to propose to this community here right now. That respect and appreciation and recognition can be a game changer for community health workers. And sometimes it is the least we get. There are meetings where I remember that a community health worker was asked to get up and give a seat to a registered nurse, not because the registered nurse was older in age, which is a cultural practice in our settings, but just because it's considered in the health system that among all the providers, the least respected is the community health worker. After all, you are the one who did not get enough education. And these are the things that sometimes will make people not wish to be community health workers or to remain as community health workers. Then the second point I already alluded to is the over-reliance on centrally established targets that are not realistic. In fact, there are many instances as a community health worker, we always talk among ourselves, how did they determine that we need to find 50 children in this village? Who came up with that number? How will they not know that that is completely out of the bounds in terms of the real number of children in these locations? And sometimes, again, that creates a lot of unnecessary pressure, and it puts community health workers sometimes in a tight spot. It is also important that the field experience community health workers we have can really contribute very novel lessons that can help to either generate new approaches or enhance the established knowledge and methods to reaching mixed communities and zero dose. And yet, more often than not, these lessons will never reach the decision-making tables, be it at the global level, national level, or subnational level. So I will propose to this team here that we need to have meaningful engagement of community health workers when planning global, national, and subnational immunization programs. What do I mean? There are meetings where a community health worker may be invited, but it is completely ceremonial. What I mean by that is that they are there, one, the space is not conducive for them to share their unfiltered thoughts on the issues or their experiences. And then sometimes in these meetings, when community health workers try to share some experiences, sometimes they are not really taken into the planning. And this, I believe, is part of the issue that is hindering our ability to reach zero dose children and mixed communities. Next slide. Again, the bridge to reaching mixed communities will be to empower community health workers. Next, please. I strongly believe that with empowered community health workers, the dream of no child, family, or community to not be missed in this life-saving mission will be achieved. And I strongly believe that we need to see community health workers as equal partners who have experiences that can contribute meaningfully at the planning stage, and not just as vessels to achieve an aim. And I strongly believe that if we adopt some of this, probably we will turn the tides we are seeing in terms of the global decline in immunization. Thank you.
George, thank you so much. That was really excellent and so compelling. And thank you for advocating on behalf of community health workers. I saw that I'm looking at the comments coming, and there was a comment from Gasper, I don't know how to pronounce your surname, Kome, but how relevant this is in his situation as well. So really appreciate these points. So we have about 16 minutes and lots of questions coming in. So I want to encourage the panelists, if you can, try to type in answers for some of the questions that are coming directly to you. Also, I saw questions about whether or not these presentation slides will be available. They will be available, as will the whole recording of this webinar on the Zero Dose Community of Practice. So please plan to check there for those. So maybe we can start. Nicholas, there are a few broad questions, I think, asking about zero dose communities. And there, maybe you can start with a couple of the questions that have come in they're a bit broader, and you've marked in the Q&A that you'd like to answer them live.
Yeah, thank you very much, Alyssa. There's a couple, actually at least 4 questions that all touch on the definition of zero dose and the purpose of having a zero dose focused. And these are very important questions, and I am happy to try to answer them. First of all, the measurement of zero dose is an indicator. That is the first dose of the DTP containing vaccine. That is not a goal in itself. The zero dose focus does not try to vaccinate more children with just the first dose of DTP. The purpose, the aim is always to vaccinate children with all the antigens in the national schedule. And I had a couple of other questions around this. One was why the indicator for zero dose is not the birth dose vaccines. And that's simply because we have much less reliable data on birth doses, on the number of children who get birth doses, and it's also very dependent on what proportion of children in a country are born in a facility. There's also one question asking why Gavi decided on the zero-dose indicator. Well, it is actually not Gavi that decided on it. It is part of the immunization agenda 2030, and the goal, one of the impact goals for immunization 2030, is to reduce the number of unvaccinated zero-dose children measured as the percentage of children who do not, or the number of children who do not get the first dose of DTP by 50% by 2030, which is a quite formidable challenge, not least because I think all of you know that the number of unvaccinated children increased by 6 million in 2021 as a consequence of the difficulties to maintain routine immunization during the pandemic response. Over, thank you.
Okay, thank you so much, Nicholas. It's really important to clarify some of these issues. Okay, so maybe I can start with, there are lots of questions for you, Dr. Jabbar. Maybe I can just start with one and then I'll switch. There's a couple questions for George as well. But one question here is coming from Ann Lindstrom. Nice to have you on here, Ann, from WHO. The question is, have you also used the COVID-19 vaccination microplanning and rollout to identify your zero-dose children in Punjab? Thank you.
Actually, we have started pediatric dose vaccination recently from 19th September up to 24th of September in 6 days in campaign mode recently. Am I audible? Hello? Yeah.
Yes, we can hear you. Thank
you. Yeah.
Previously, we started COVID vaccination above the age of 12 years. So we are not using this definition for COVID vaccination as zero dose. We consider every child which has not started its first dose, initial dose of BCG, OPV polio, and hepatitis birth dose. He or she is labeled as zero dose. From our programmatic has given us the definition of zero dose up till Penta 1, DPT containing vaccine. So as a rule in Punjab, we don't spare any child or any of our worker whose UC is having a child not touched or registered by a vaccinator up to the age of 40 days. 40 days is the maximum time limit that vaccinator is supposed to go to the community, register the child through LIW, lady health worker, and vaccinate him or her by all means. There are certain modalities that pick up the zero-dose children from the community. For example, when the program goes into the community in campaign mode, whether polio campaign or other many campaigns are there, multiple strategies are working in the community. A huge workers are from UNICEF, WHO, from government. The people, they are in search of these zero-dose children. Actually, this is our weak point. Wherever we found zero-dose children in a community, in a union council, the vaccinator and the health administration is answerable to that. Why your UC is having so many zero-dose children? You check that contains this zero-dose indicator. The health department, the secretary, and the minister, they themselves are present there. and the health managers are answerable in front of them why your UC is so weak while considering EPI services, especially zero dose. So this is the success story in Punjab actually. The accountability is very strict. So many people, they have lost their jobs and they are held accountable for their performance in EPI services. EPI is the top priority #1 agenda of the health managers in district health departments.
Thank you so much, Dr. Jabbar. You're breaking up a little bit, so perhaps if you can look also in the Q&A, there are many questions for you, so maybe work on some of those in the meantime. George, I wanted to ask you, there are a couple of questions coming in that people wanting to know a little bit about more about the context in Ghana. Bagoro and Bonaventura are asking, are the CHWs paid, and how do you deal with retention? Also asking specifically about the challenges, Bonaventura is asking about the challenges reaching unvaccinated children whose parents are either not educated or poorly educated. You know, what's the situation in Ghana, and how can CHWs, how are they capacitated to handle this challenge? Over to you.
Thanks, Alyssa, and thanks everyone for the positive comments. Really appreciate that. First of all, yes, in Ghana, after a long haul of negotiations and research, eventually, yes, community health workers in Ghana are paid. Issue about retention. To be very honest with you, the dream of almost every community health worker is to not be a community health worker. Not because they don't like the work, not because we are not appreciated. To be honest, the lifeline or the one key motivation that keeps us in the field to do the journey I shared the pictures with you is one, most of us are from villages like that. We grew up in villages where there were no health facilities. We grew up witnessing our friends and sometimes siblings dying from preventable diseases. And for the love of that, that is the key motivation. You go into these villages, they call you a doctor because you are all they have known in terms of health services in the country. And that is the key motivation that keeps us making that extra mile, climbing the hills and crossing the rivers. Now, in terms of the key challenge, to be honest, is about usually the engagement of a community health worker with a formal, higher level, like supervisors, district health management teams. That is the area you can face the real challenge and demotivation from. And that is mostly, like I said, I mean, I know this may sound absurd and many will not understand it, but it is just the basic respect. Sometimes in the way of just even talking to a community health worker, in the way of treating a community health worker in the midst of the different cadre of health workers. Sometimes, to be honest, that is the main motivation for why many of us will not like to be community health workers. And this is an area that is least touched on. A community health worker who sometimes speaks out, you are likely to lose your job or get tagged. I know community health workers elsewhere that are being called ministers of health because they have called out an issue that is challenging authority. And these are the areas in terms of talk of retention, ways to increase retention and ways to keep community health workers motivated. It is usually the engagement with the higher level. That is where the real issues are. And then in terms of the communities, you talk about low education and stuff. To be honest with you, in my experience, that is usually, most of this, the people we serve in this setting are very, very, very appreciative. I mean, I have never gone to a village and come back the same. By the time you come back, they load you up with food from their farms, and like they treat you like a king in the health sector. They know the importance of the service you are bringing to them. So usually that is not a problem. The true challenge and the true reason sometimes for them not being able to make the trek is the road conditions I have shown to you. It's a farming season and they need to be at the farm. And you have seen in my pictures, one of them where sometimes the car, you drive halfway, and that is how far a car can go. They will walk the other halfway. You meet in the middle of nowhere. There's no structure whatsoever. And then there you provide service. So in terms of the idea that maybe due to their low education and poverty, they don't know the importance of immunization, at least in my experience, that was not the case. In my experience, a lot of it have to do with the real challenge. And in terms of going to facilities, a lot has been published, and I wouldn't take too much time on that. But yes, they come to communities and they get, sometimes at the facility-based service, depends on who is there, they get treated like you are dirty, they get insulted, they get charged monies they are not supposed to be charged. But again, these are already well-established facts, so I wouldn't dwell too much on that. So yeah, with respect to these 3 points, I think these are the things. And some of this, we can write a book on it. It's long and we can talk all day. But in short, I think this is what I would say with respect to that.
George, thank you. I think I love the perspective that you're bringing, and there was also just the sensitivity to the needs of the communities. It's really inspiring. Maybe Dr. Jabbar, can I ask you to answer live? We only have a few minutes, so maybe within a minute, if you don't mind. There are a couple questions relating to the night shifts that you talked about and how those are feasible, whether or not all the facilities have electricity connections, if that's reliable. I think they're also just curious in general what this means for the health workers, and are the vaccinators able and motivated to provide the services in the evenings, because there are challenges. So maybe quickly, if you don't mind, you can just address those questions.
Thank you. Actually, the round-the-clock services, 24/7 services of EPI, they are rolled in teaching hospitals, DHQ hospitals, THQ hospitals, and 24/7 BHUs. There is a knockdown criteria in these institutions. Whenever our health manager visits the health facility, electricity is a must. Logistic support, and there is a watchman, there is a security guard, and the staff nurses who are conducting duties over there, they are trained. At one hand, they are conducting deliveries. When there is a newborn baby, the initial labor room vaccination, especially the BCG, OPV, and hepatitis B burst dose, that is given then and there. The card is being issued to them. Logistic support is with them. They have got the vaccine carriers, the vaccines, all the routine vaccines. They register the child then and there. So then it is taken up by the vaccinators in the coming days. This has been strengthened by the Secretary, Primary and Secondary Healthcare and Health and Education Department. Wherever there is no electricity, no fun of having this ILR and vaccine storage. They collect their vaccine from the nearby EPI centers in standard vaccine carrier, do the vaccination services, and then come back to those centers to relocate, to place the vaccines at when the session ends. Over, please.
Okay, thank you so much, Dr. Jabbar. We're running out of time. Maybe just one last question, Ria. I wanted to bring you in here. I thought there was an interesting question from Dr. Ravisha Mugali about what's the challenge. We know that the families and the children living in these zero-dose communities have multiple deprivations. So why isn't integrated service delivery happening? And I think the question was specific to Pakistan and Ghana, but I'm just wondering if you have, more a broader overview of what some of the challenge is to this globally. Over.
Actually, Here, our programs, they are integrated. They are working under one DG, Director General Health Services. The LHW program, the national program where the lady health workers, they are being paid from their national program. There is the intensive training for them. They do the job of social mobilization. They register the child in the community. Whenever they come to the center for their monthly reports, or the vaccinator reciprocally goes to the community, he go directly to the LIW house, and the LIW announces through mask. There is the mask announcement. The vaccinator will come on this day and he will sit on this spot. The spot is called kit station, where the vaccine services are done. It is reflected in the micro plan of the vaccinator that he or she is supposed to be in the community for 16 to 22 days a month. And this is real-time data being reflected on EMR, secretary, minister, and all the health high-ups. They directly see all that data. So there is a strong accountability mechanism of the district as well as the vaccinator. They are answerable to all their performance, whether the person is not marking his attendance through that dashboard system. Say I am a vaccinator. If I am not attending my clients, my eligible children, the system is that these vaccinators of the district have not done their duty today. So they are answerable to their district administration. And in the monthly review meeting, the district managers are supposed to answer in front of the secretary and minister why you people are not controlling these people for the needful job. Over, please.
Thank you so much, Dr. Jabbar. So we are at 3 minutes after the hour, and I'm conscious of everyone's time. Just wanted to quickly thank our 3 fantastic panelists today, Rie, Dr. Jabbar, Georgia Munya. Sincere thanks to all of you. And please, everyone, know that you will have access to this recording, to the slides on the Zero Dose Community of Practice website. And if you have further questions, please do feel free to contact through that website. Thank you, everyone. And it's been a pleasure to be with you. And have a good day and evening.
Thank you very much.
Thank you very much. I really enjoyed this.
Thank you.
Thank you very much, all of you. The hyperlink to the Zero Dose Community of Practice website is in the chat. And Alex, could you please roll over the last slide? And it's also indicated on that one.
Nicola, thank you very much for conducting such a marvelous session, please. Thank you.
Thank you very much, Dr. Jabbar. It's a pleasure to have you here.
Nice
Thank you, George, and thank you, Rie. Goodbye to you all. And please, as I said in the start, this is the 3rd of a series of 3 webinars. The next one will be next week on Wednesday, and that will be on the challenges of providing immunization in urban poor areas, in slums. So please spread the word to your colleagues and partners about that webinar as well. Thank you. Bye.
Thank you. Bye.